update about what the cost. Yeah, Bianca and I will give an update on what the cost board has been up to, and then we will have a presentation on the data call and the implementation of some of the bills that were passed this last session. So we'll start out with roll call. And I'll call the roll, and I ask you to, I'll call your first name, the order that's listed on the agenda. And then I'll ask you to unmute your microphone, let us know that you're here, and tell your title or your affiliation, the organization you're representing. And then we're also asking that if you want to include in the chat what places you like to visit in Washington during the fall. And so with that, I'll start out with the Data Issues Committee. Krista? Krista here?
Oh, good morning. Sorry. Took me a little bit to get off
That's fine.
of mute. Good morning, everyone. It's not even morning anymore, so I'm really losing it today. It's Krista Abel. I'm a director at Virginia Mason Franciscan Health. And favorite places to visit, just the Pacific Northwest, wooded areas, chanterelle mushrooms, which I mentioned on a previous call, and this time of year, the fall is gorgeous.
Okay. Nabucci? Is Nabucci here? Okay. Megan? No. Amanda?
Hi, good afternoon. Amanda Avalos from the Washington State Healthcare Authority. I appreciate all of Washington. Even my commute to work is a beautiful drive with lots of fall foliage. So.
Okay. Jonathan?
Yeah, Jonathan Bennett from the Washington State Hospital Association. I just joined, so I'm guessing we're talking about favorite places in the Northwest.
Yes.
Yeah, love the Oregon and Washington coast. I mean, it can't beat that. So I also just want to know I am traveling back to the office, so there is a possibility that I'll drop off, but just wanted to let you know that. But I should be in my office in the next several minutes.
Okay. All right. Bruce?
Hi, Bruce Brazier, Administrative Services Director, Peninsula Community Health Services. And I gravitate towards the Yakima Valley during apple harvest season.
Okay. Jason?
Afternoon, everyone. Jason Brown, Budget Advisor for Low Income Health for the Governor. I really enjoy driving the roads just outside Ellensburg in the hills, right outside there during the fall. It's beautiful. Thank you.
Okay. Chandra? Not here. Leah?
Hello, everyone. Leah Hole Marshall. I am General Counsel and Chief Strategist at the Health Benefit Exchange. And my comments are in chat. Thanks.
Okay. David?
Yeah, David Mancuso. I'm an economist with the DSHS Research and Data Analysis Division. I've really enjoyed the Staircase Campground area when it's not on fire.
Yeah, we hope that gets under control. Anna? No? Hunter?
Hi, this is Hunter Plumer. I'm a health economics consultant for a variety of health systems here in Washington State, and then also help do some teaching at University of Washington as well with the MHA program.
Okay. Mark?
Good afternoon, everyone. Mark Pregler, Director of Data Management and Analytics with the Washington Health Alliance, and I enjoy being anywhere out in the woods or on a golf course this time of year.
Russ?
And Russ let us know that he will not be able to join today.
Okay. Mandy Staher?
It's Star.
Star.
This time of year is kind of when I get to do the kid-friendly hikes. So, less bugs and kids can stay a little bit more focused instead of screaming and running away from bugs.
And who are you with?
OFM.
Oh, okay, sorry. Julie? Okay, then we'll move on to the advisory committee for healthcare stakeholders. Emily?
And Emily will not be able to join today as well.
Okay. Patrick? No Patrick? Dr. Bob? Well, we're not doing well here. Paul?
Oh, you're looking for Paul Fishman or Paul Schultz?
Well, Fishman, but we'll take Schultz since you answered.
Well, Schultz is here.
Oh.
I'm Paul Schultz. I'm Executive Director of Actuarial Services for Kaiser Permanente, and I'd love getting out to the coast in the fall or any time of year, really.
Okay. And what, another try, Paul Fishman? No. Jamie? No. Justin? Jody? Louise?
Hello, I'm Louise Kaplan. I'm a family nurse practitioner and I'm representing ARNPs United of Washington State. And I think anywhere in Washington is wonderful any time of the year. And I especially like hiking at Mount Rainier and out in the Olympics.
Okay. Stacy? Vicky? Natalia?
I'm here. Good afternoon. I am the co-president and CFO for Multicare's Behavioral Health Network. I too love Everywhere Washington, and I also really enjoy the coast, Washington, Oregon coast.
Thanks. Sulan?
Hey, it's Sulan Milneric from SCIU 1199 Northwest. Happy to be here. I love the loop around Wapato Park in Tacoma with all the pretty trees.
Okay. Michelle?
Hello, Michelle Ritala with King County. I'm the benefits strategist there. And I agree with everything everyone said and hope we get some good rain so the fires will be put out and we can go back to hiking.
Okay, we've already heard from Paul. So Jeb?
Good afternoon, Jeb Shepard, Director of Policy with the Washington State Medical Association. I'm an interim member of this committee while we seek to fill our spot with a physician. And agree with everything that's been said. I'm looking forward to the rain the most, regardless of where I'm at. And I like Hood Canal, like the Hood Sport area.
Dorothy?
Hi, Dorothy Teeter. I'm a consumer representative for this group, and I love going to the Yakima Valley in the fall.
And Wes?
Hey, good afternoon. Wes Waters. I'm a regional chief financial officer for Molina Healthcare with primary responsibility for Washington. Love all parts of the state. I think my favorite is the Olympic National Park area.
Okay, and then I think there's some joined well that I already got past. I know Chandra.
Yes.
I'm here. And Anna Morales to see Anna.
So we have Chandra and
She
Anna
here.
noted as joining. And I will note that we have a quorum for the Data Issues Advisory Committee, but not the Stakeholders Advisory Committee. So as we move into our next section, we can review the minutes, but we will not take a vote today.
Okay. Yeah.
It looks like Bob Crittenden may have joined.
Oh. Dr. Bob?
Hello,
Okay, you are there.
I am here.
Okay. Does that get us a quorum? I don't think so.
Unfortunately, no.
Okay. Well, we'll just have to move on then. So I guess we can just skip the approval of minutes since we can't take a vote on it.
I would suggest
And
we can review them. If anyone has comments, we can make those edits in the meantime.
that's true. Anybody, yes, does anybody have any comments or changes to the minutes from May? I don't see any. So guess we can go to public comment then. Do we have any, Harrison?
All right. We did not receive any public comments ahead of time, but we have the chance for folks to provide public comment in this section. If you're a member of the public that wishes to provide comment, please raise your hand. When you're called upon, we will transition you over to a panelist. Please accept that, and you will have 2 minutes to speak. With that, I will open the floor to folks to raise their hand to provide public comment. And Katerina, I believe I saw a hand from you.
Hi, thank you. I'm Katerina LaMarche. I'm a policy director at the Washington State Hospital Association. We really appreciate giving the advisory committee members the opportunity today to consider and provide feedback on what we think are two critical issues. One, how to improve the benchmark methodology and the attribution methodology. But we think to provide the most informed feedback to the board, the discussion should be thorough and the issue should be well vetted. And we aren't sure that there is enough time allotted today to do that. We also think that a thorough discussion should include an opportunity for advisory committee members to review in advance and discuss feedback that's already been submitted on these topics to the board. And that includes feedback from the large provider entities subject to the benchmark and the comments that we and others have provided on behalf of members that are subject to the benchmark. And we think it's important to do this because updating and improving these methodologies is technical, and feedback from entities that are subject to the process could really help best understand what's working, but also where there are issues like process and interpretation challenges, data gaps, usability, data accuracy, transparency, so that any updates result in sort of the most relevant, accurate, actionable information for providers to use when determining how they can contain healthcare cost growth. So once again, really appreciate that updates and improvements are being considered, but hope that the process is thoughtful and thorough. Thank you.
Thank you. And next up, I believe we have Teddy.
Thank you. Good afternoon. I am Teddy McGuire on behalf of Providence. We did submit a response to this year's report, but I wanted to touch on some highlights for the committee for today's discussion. First, we agree that the benchmark needs to be updated, and the data presented should explain the nuance within it. The aggregation of data at the provider entity level poses significant challenges for us to validate and does not provide actionable information for us to track and analyze costs, understand whether there are outliers to be addressed, or take actions to manage costs. Without more granular data, we cannot leverage this information in a meaningful way. Providence provided TINs to the board for the purpose of directing carriers on which data to include, and it seems possible to request the data back from carriers in this format for inclusion in the reports back to providers. This level of detail is crucial for making comparisons across facilities within our system. The ability to validate data and identify areas of improvement is critical if we want these reports to drive a change. Second, if context is not provided as to how the data is calculated and weighted, nor for why the cost growth occurred, erroneous conclusions could be reached that in turn spur detrimental policy proposals. Much of the claims data that is pulled from the APCD ends up being filtered into total spending per diagnosis code, but it does not compare the cost of a specific service year over year to see if the cost for that service has increased. It only shows whether total spending has grown, which could also be due to increased utilization. Regarding the cap, healthcare is not immune from the rates of inflation, which we have seen in the broader economy. In 2023, the Washington inflation rate was 4.1%. Inflation was last below 4% in 2020. Further, it does not reflect the realities of healthcare-specific cost, especially for pharmaceuticals, supplies, and labor, which are not in our full control. The Medicare Economic Index, which reflects the actual annual inflation for healthcare, was over 4% for 2023. We are happy to provide more detail and further conversations, and we look forward to partnering in this work. Thank you.
Thank you. We'll hold the floor for one more second for anyone else to raise their hand if they have any questions. All right. Looks like no more public comment. We can move on to our next section, which I believe is Bianca and Eileen with cost board updates. Bianca.
Bianca's here, right?
Are you there? Not seeing her. Eileen, do you want to?
Okay. Well, I hope things are going okay for her. All right, so I will just go ahead and start us out here on the cost board updates. We on June 3rd, we gave a summary of the Joint Advisory Committee feedback to the cost board, which since not that much of that my committee is here, but they would remember what their feedback was. And we also reviewed the scope and multifaceted approach of the cost transparency, and we'll show you a graphic of that in the next slide. And on July 22nd, the panel of agency staff and panel of payers were together on anticipated federal income impacts in Washington State, which there are plenty, and we have quite a few slides about that coming up. So, and this is a diagram of our multifaceted approach that we are using. Oh, but Bianca's here now. But she just sent a message. Bianca, do you want to take over?
Okay, I'll try to do this slide and then I'm sorry, after passing this back to you, Elaine, I will probably have to move. I apologize. I seem to be having problems getting back on. I mean, basically, the point here is that the cost board has, at the end, of course, at the center of what we're trying to do is try to think about how to address affordability of healthcare in the state. And there's a multifaceted approach by which we're going about this. So it's a constant kind of fluid thing that we're doing where we're, of course, wanting to assess the state of affordability of healthcare in our state. As we look at the benchmark, we're trying to see how the state is performing against those benchmarks. And then we've been reviewing strategies to improve that, then identifying what are the areas that are actually improving, what areas remain at risk. And then, of course, there's a number of things happening at the federal level that have an impact on our state. So we're assessing how is what's happening in the state being impacted and what does that mean for cost. And so many of the topics that we've been talking about, we've been addressing many of these points at any one point in time, sometimes all at the same time. But this visual is just really meant to kind of help identify some of the activities of the cost board and how we generally go about our programming. So, Eileen, I'll pass it back to you. And I'm sorry, I'm going to just have to step off for a little bit.
We'll hope you find a good connection.
Thank
you. All right. So then on the next slide, I'm going to go through a bunch of these slides, which are a lot about the federal changes that we are facing, and we have like best thoughts on what this is all going to mean. Hopefully there will be changes. That's all I can say. And I would remind everybody that we also are facing a budget challenge here in Washington State. So all of this is kind of grim news, but also points out the necessity of the work that we're doing here on the cost board. So health coverage is what are estimating through the exchange, and this is all, well, not all from the HR1, but HR1 and the fact that the tax credits expire at the end of the year. And that's, as you probably all are aware, that's one of the big fights that we're having on whether there's going to be a federal shutdown or not. So that remains to be seen. But at this point, they're scheduled to expire December 20 in the end of December. And with that, Washington would see a reduction in coverage of 35 to 50% in the exchange. And the premium increases are up to 15%. And actually, I think that when this was presented, it was before the releases, and I think it's actually a little higher than that now, or at least can go up a little higher than that. And so there will be ripple effects across the health system with an increase in uncompensated hospital care. So next slide. And this is on the health benefit federal changes to the CMS marketplace. Is that, as again, affordability and benefit changes, a shorter time to sign up, and the eligibility is becoming narrower. So the enrollment reduction of up to 23% just from CMS marketplace. So next slide. And then again, this is like spelling it out in a different way about with the enhanced tax credits going away, what we think that this will mean. And then there's increased eligibility restrictions in 2027. It's the APTCs that will go back to what they were prior in 26. Then there's increased eligibility restrictions in 27 and pre-enrollment verifications in 28. So it just keeps getting a little harder. I'll just phrase it that way. And I don't know, don't think there's anything on this slide that even talks about the fact that we're going to have to put up a new computer system or make big changes for eligibility and trying to move forward on this. So next slide. And this is on the Medicaid side. As I'm sure you're aware, that the prohibiting payments to family planning providers, we're increasing the eligibility redeterminations, despite the fact that we had expanded it as first on children because it was cheaper just to cover them than to go through the redeterminations. I can't help but do my aside on some of these things that are being required. Then the increased work requirements on the Medicaid eligibility, it's either work or volunteer activities. And the changes in the provider taxes that will be decreasing the amount of provider taxes and then also reduces the amount that we pay providers. And a cost sharing requirement, which have history of that, oh golly, quite a while ago, where we had during a time we had in the state where we did have cost sharing, and what happened was that the providers had to basically eat it. That did not actually help in getting the costs down. And then the removal of good faith waivers with erroneous payments. Next slide. And this is another slide about the impacts. And we're projecting 200 to 320,000 Washingtonians will lose Medicaid coverage, and that the state will lose billions. And as this all between 25 and 2034, it's over the 10 years. Hopefully our economy will improve by then, but at this point, our state budget will not be able to put those funds back in. And we're still assessing the full scope of impacts, but there will be new state costs, as I was referring to, just the computer systems to try and track and the increase on the changes there. Next slide. And this is on the direct payment system. And this definitely will have some impacts, especially on Harbor U, University of Washington. And it will reduce over 1.5 billion when it fully goes into effect over the next 10 years. And that also, as emergency, you can see all the list of things that get affected by that. Next slide. And the good faith waiver removal will reduce federal investment in Medicaid by over $7 billion over the next 10 years. So these are all things that are compounding that will be causing us trouble over the next several years. Next slide. Oh, and then rural health. And I'm sure, since I know we've got several of the hospitals on our committees, the rural health is definitely worried. They did put a $10 billion investment to try and mitigate, but that's only a small portion of what's going to be cut. And they have put out the applications now, and they have to make the applications have to be approved or denied by December 31st. So I think it was last week or the week before that the application came out. But the funding can be used to support rural health transformation projects. And so that work is being done now, and I don't know whether any of the staff has any more updates on this, but I don't know where exactly we're at on it. But I know that we're looking and trying to have a transformation plan to go in place. Next slide. And then, yes, as changes in qualification in 26 for refugees and non-citizens. Another one that hasn't had a lot of press is about revising the home equity limit in long-term care eligibility in 28, which that will have an effect on nursing homes and our elderly populations. And the changes, shortening and retroactive coverage for those that are approved for Medicaid. If you meet people that are not on and they go into the hospitals, and they can get retroactive coverage. Sometimes it takes a few months to get that in, but they're going to reduce the retroactive eligibility, and changing the address verification process in 29, at least that's a few years out. And then limitations on the enrollment windows and the premium tax credits for individuals in the individual market on the exchange. So next slide. Oh, and we had presentations, and these were some of the concerns that were brought up. This was from the SEIU providers, or the Home Care Workers Trust, and the Health Benefit Trust. And there's big concern about the loss of jobs and delayed services throughout the changes, and the strain that the hospitals will feel when home health breaks down. So I think that's all of those are all things we are aware of. And then we had a presentation, the next one, from Dr. Bonato at SHARP, the Safety and Health Assessment Research for Prevention. That's what that stands for. And that the federal changes to occupational safety and health, eliminating federal grants for that. There's a huge concern about how that's going to affect our training for occupational medicine docs, including a program here in Washington State. And that exacerbates the existing shortage that we currently have of occupational medicine providers. And then as it says here, research has shown that about 50% of the work-related injuries that are not paid by workers' comp, and they're absorbed by the health insurers. So these impacts make healthcare more unaffordable and worsen a workforce shortage for occupational medicine providers. And is that the last slide? Yes, it is. So I don't kind of whip through that. Are there questions from anybody on the panel? Can I see? Don't see any questions. Okay. So I guess then we can move forward to the presentation on the data call from Amanda Avalos.
Yep, so next up we'll have Amanda Avalos, the HCA Deputy Director for Enterprise Analytics, Research and Reporting. She'll provide an update on the data call, including some background and some current progress and areas for future improvements. Looking forward to the presentation and discussion after.
Thank you, Harrison. So hello, for those of you I haven't had a chance to meet yet. Although I am a member of the Advisory Committee for Data Issues, this presentation is me representing the data team here at the Healthcare Authority that supports the cost board. So next slide, please. All right. As you know, there's a lot of different data-related work streams associated with the cost board. So to level set and make sure we know what we're talking about here, for the next several slides, I'm going to be discussing the performance against the benchmark. So as you know, this is the assessment of cost growth against the benchmark target. We refer to it as the data call, that the data is collected as specifically for the purpose of the report performance against the benchmark. So we have lots of other work streams related to data, but we'll be specifically talking about this one today. Next slide. All right, so here is an overview of the process. This is the data call timeline. You probably have visibility to the end of the process, but we wanted to highlight this so you can see it in its entirety. So in December and January, we start off with the design of the data call and the launching. So updating frequently asked questions and the data submission guide. It launches in February. During March through June, we have the data submission and validation process. So this is where there's technical assistance, there's webinars, conversations, sometimes one-on-one, a lot of interaction with the carriers that are submitting the data as part of the data call. We also receive the submissions in April, but then there may be follow-up discussion one-on-one, particularly as we're identifying any challenges or questions or data anomalies. So that validation happens then. In July and August, we're moving into the initial analysis, and we're also generating the carrier and provider reports. There's an opportunity for the carriers and providers to provide feedback. So there's more dialogue and conversation between the Healthcare Authority data analysts and those provider organizations that may have questions or concerns. And that's discussed during this July and August period. And then we move into August through November, and this is the exciting, probably more visible part of the process, the final analysis. The reports are generated for the board meetings and the advisory committee meeting. There's also the public hearing where the performance against the benchmark report is unveiled and public comment is taken. And although that's the end of the process, it's also the beginning of the next round. You see that in November brings us right back to the beginning. We try to take the learnings and the feedback and the input that we hear from each data call, and we put that into the design of the next subsequent data call. So it's really that continuous quality improvement and listening to the data submitters, as well as those that are receiving the reporting, such as the board. Next slide. And feel free, if you have questions, to put them in the chat or jump off mute. So one thing I want to note that happened as part of the 2025 data call, we had an updated primary care definition, and this was specific to claims. And I want to highlight that because we'll talk a little bit about non-claims and the primary care definition later. But within this last data call, we had an update. Instead of the definition that we previously used for primary care, we moved to be in alignment with the Advisory Committee on Primary Care's definition, which they created. And we are now using that technical definition that has some changes. One of note is the inclusion of place of service codes. There was also updated provider taxonomy and updated procedure codes. And you can see this graphic really shows that to identify primary care, it is the location of where that service takes place, the provider who's providing that service, and then what those services are. So all of those ingredients together go to that definition, which is slightly more refined and narrow than the previous definition. It was really important to look at this definition. We want to make sure that as we're looking at healthcare costs, we're able to evaluate the primary care spend relative to the target that's been set at 12%. Next slide. All right, so I want to touch just briefly on potential changes that are going to be happening in upcoming data call. Some of this is sort of behind the curtain, at least for that first one. We're going to have a new automated data collection tool that is intended to really help support the technical data validation, which can get complex, and having an automated data ingestion tool can help improve some standardization. We're still learning some of the features and functionality of this tool. Most of the changes related to it would be internal changes in our operations, with maybe some minor changes that will be impacting the data submitters, and that information will be included in our technical data submission guide when that is unveiled for the next year. Another change that will happen, earlier in the slides, I talked a little bit about the primary care expenditures for claims and how we have that new definition. In the future, we haven't done this yet. In the future, though, we will be looking at including non-claims based primary care expenditures as an element that will be collected as part of the data call. Obviously, that's an important piece that we want to make sure when we're looking at primary care expenditures, it's comprehensive and it also includes those non-claims expenditures. I'll talk a little bit more about this on the next slide. So next slide, please. All right. When we talk about non-claims, I've been in some conversations that really kind of what do we mean when we say non-claims? So as we look at updating the technical manual to capture non-claims, what we'll be talking about is capitation payments, salaries, incentives, population health payments, and practice support payments. And there'll be guidance, technical guidance to help data submitters understand how to provide that information for non-claims as it relates to primary care. Next slide. All right, and so a little further out on the horizon, we have heard from some of you and others that there's interest in approaching, revisiting some of the approaches that we have within the cost board data call. So the first that we're going to be looking into is the recalculation of the healthcare cost growth benchmark. As you know, the benchmark was set by the board several years back, and we're going to have opportunities to discuss and refresh with updated data. And the second consideration is the revisiting of the attribution methodology used in the performance against the benchmark analysis. Really, the intent and the purpose is to improve the attribution of healthcare spending to inform policy discussions and options. We want it to be something that really serves the needs of the board. And so to that end, we're going to have conversations and dive into revisiting the methodology. This is just the beginning of that conversation. So there's going to be a lot more to come. Next slide, please. So a couple of reminders about really that the healthcare cost benchmark. For those of you that don't remember those conversations, years ago when this was set by the cost board, that the benchmark is the annual rate of growth target for healthcare spending in the state. And it was designed as a 70-30 weighting of historic median wage growth and per capita potential gross state product growth. You can see here the calendar years that were set and the benchmark value for those calendar years. I would just note that although we're approaching 2026, this is calendar year of the data itself. So there's, of course, a data lag. So these would be corresponding with the data, not necessarily the calendar year that we're in currently. And next slide. And so let's talk about the current attribution methodology, just to remind folks that right now, as we're attributing costs, they're going to be attributed by primary care provider-based attribution. And so we'll take an individual member and their associated spending and attribute that to the primary care provider, and then attribute that primary care provider to a large provider entity. And you can see that as this attribution is made, there is a hierarchy of how the attribution is made and really focused first on the PCP selection by the member as required by the plan. And if that is not possible, the contract arrangement between the carrier and provider. And there's also the utilization history as part of that. Next slide, please. All right, so I'm going to move into listening mode along with the data team from Healthcare Authority that's on the line. We have shared that we're starting to revisit some of the approaches and the methodologies that are used in the data call. And we know that there are ideas and thoughts on this, as well as other ideas related to potential quality improvement opportunities in the current process. So I'm going to start us off with a few questions, and I would love to hear feedback. So the first is, do you have any recommendations related to the current process? Nice broad question.
Hi, this is Wes Waters. I do on the prior slide have one question just for clarification and understanding. In your second bullet, it says contract arrangement between the carrier and provider. Can you elaborate for a moment on that?
Certainly. So
what that means, a little bit more detail. Thank you.
Yes. So this is around the primary care arrangement that is listed specifically in the contracts of who and the primary care providers that have contracts directly with the carrier. So the organizations that may have contractual arrangements. I'm not sure if that gets to the heart of your question, if there's a specific.
No, I that helps. I was just trying to understand if you're assigning the cost to the PCB by looking for the members and tracking them to the PCP, then to the large providers, what the arrow indicates. I was just trying to understand the contract arrangement between the carrier provider, how that fits, meaning the contract arrangement between the managed care company, so to speak, or the insurance carrier, and you're tracking that cost back to the primary care. I'm not exactly sure how you're tracking costs based on that. I just wasn't following that logic.
I see I've got a couple other hands up. Real quick, if there's others from the team that want to talk specifically, I don't want to go too far out of my own expertise as it relates to how this is done between the contract arrangement between the carrier and others. So I'll take that question and then maybe able to follow back and loop back with the answer or more detail.
That's absolutely fine. Thank you.
All right. And then Mandy, it looks like you have your hand up.
I'll let Jonathan go first and then I'll ask.
Yeah, so on your that future consideration slide, I was just curious. You had mentioned that the team is going to be looking at revisiting the benchmark, utilizing more current and updated information, which we agree with needs to happen. I was curious, what's the timeline of that process and ultimately who's going to be involved? And once you revisit that, does that mean you're going back to prior years to have an updated cost benchmark, or is that for future years? I'm just trying to get some clarity there.
So Jonathan, the first thing I'll say is that this is the very beginning. So timelines and project plans and all that absolutely will be developed, as well as the scoping of what that really means. At this point, I think what we would love is to hear perspectives from you and from others about what's important to consider as we're starting to do that.
Yeah, I mean, I think for us on the current kind of approach of establishing the benchmark, only 2% of the inflation is brought into that. I think for healthcare, it's much bigger than that. We want to make sure that that's really weighted in as part of that conversation. Because if you look at healthcare, I mean, you got to look at the labor, you got to look at pharmaceuticals. There's so much more that is driving that. And to have a benchmark that is credible, you have to be looking at these external factors.
Appreciate the comment, Jonathan. All right, Mandy.
I had a question regarding the attribution methodology that you're using, that you've got the slide up here. Have you all looked at how this compares with how OnPoint does the attribution with the APCD data? Like compare and contrast it?
I might not be able to give specific response to that. I will note though that Mandy, that the way the OnPoint and the all payer claims database analysis are done is quite different because the very different nature between the two different data sources. Data from the data call is already pretty aggregated and coming directly from the carriers, whereas there's a little bit more flexibility potentially with the all payer claims database because of the fact that they have the claims detail information.
Okay, but so you haven't really systematically looked at how they differ when you look at the attribution?
No, but I can say that the attribution methodology that's used for the data call is very similar to what is seen in other states' data calls. So when they're receiving that carrier information directly, we haven't compared it when doing attribution with claims-based data.
Okay.
And just
All
an
right.
additional clarification there, the on-point analysis does not stratify by provider, so this attribution issue shows up differently there.
Thanks, Harrison. And Harrison, did you have a question also or comment?
Sure. So just raising one issue that has been brought to the group data team sort of collectively throughout this current process that we're in, which is sort of the providers reviewing their reports and potentially getting linked up with carriers to sort of dive into the details behind that data. And one issue that's been identified for us is that the providers have contacts, especially through contract arrangements, with that they would be hooked up with on the carrier side. Those sometimes aren't the right people that know the details and the ins and outs of these data reports that have been given to the HCA. So one thing that we'll be doing going forward is facilitating those connections, essentially providing the correct contacts on the carrier side to those providers who are looking to learn more about the intricacies of the data behind those provider reports.
Thanks, Harrison. So I think I was hearing you say that there'll be more direct contact for easy connection between any providers that have questions and the carriers that submitted the data that included their results.
Correct. Yep.
Excellent. Thank you. All right. And then I did get some updated information. So Mandy, just to come back and clarify, although the all payer claims database has lots of different analysis specific to the cost board analysis, or excuse me, the cost driver analysis that the cost board has seen, there is not stratification by provider. So that's not something that is comparable to what we do for the data call. So hopefully that answers your question.
Yeah, I was thinking more about how they do the review and reconsideration with the attribution on that point. So it's more internal to the APCD versus reports that they actually do. So that's more of what I was getting at, was methods that they use.
All right. Yep. Understood. All right. And Jeb, it looks like you have a question.
Yeah, thank you, Amanda. More of a couple comments, if I may, just about the benchmark and the attribution methodology. Agree with the comments that have been made and appreciate the healthcare authority revisiting the benchmark to just sort of calibrate and make sure that it's more reasonable and appropriate and achievable. In terms of the attribution method, I think one of the things that confuses our members is at times the patient attribution methodology is non-standard and is carrier specific. And it's my understanding that the different carrier methodologies aren't shared with the provider groups in the reports. So I think it would be helpful to include um, uh, those details in the reports. And then, something that we've raised several times, and I don't know the best solution to this, apart from providing context, is some of the physicians that we've spoken with, this attribution methodology that we see on the screen is like they're very familiar with it in the context of value-based payment, and they said it makes a lot of sense there. When you start to publicly report against a benchmark, we feel like there's some important context that should be provided in terms of if a patient is assigned to a specific physician group and then that patient is hospitalized, those hospital costs that were not negotiated by the medical group are attributed to that primary care physician. And I don't have a good solution of how to address that. But when we're publicly reporting this stuff, I think that kind of context would help.
I appreciate your comment, Jeb, and definitely encourage you and others. If we think about reimagining the attribution methodology, although a solution may not be readily apparent at the moment, what considerations and what ideas would you and others have to contribute? Thank you. And then Krista.
Hi there, Amanda. I'm essentially going to read the information that our analyst, the manager of our analyst department, our finance department, shared with me about the recent data call. And the first one is about the attribution methodology and requests that the attribution methodology is standardized. And so it goes along with Jeb's comments that there are several different attribution methodologies that makes it complicated. So if there was a standardized attribution methodology, at least we'd have a better understanding of who would be attributed to us. And he says here contractual agreements could still take precedence, but without a clear-cut procedure for remaining patients, how do providers know who else might be attributed under this benchmark? The second comment is about the cumulative. Actually, this is year over year. And so his comments are about how one good year could be followed by a bad year. If you have a good year, it lowers the bar, and then the next year you have a bad year. So their preference is to have a cumulative approach as opposed to year over year. For that reason, to have separate benchmarks for pharmacy and medical claims. He's saying that there's a large driver, that the pharmacy is a large driver of increase in PMPM. And so it would make sense to separate those two categories. And then last one is also about the cumulative versus year over year. Measure the cumulative percent change from a multi-year benchmark period. For example, a 3-year average of the years before the benchmark is established. This would help reduce any discrepancies in a single base year. And for example, having a high spend base year makes all following years look better. And this is how Medicare works in their MSSP program. So I know that's kind of highly technical, but that was the feedback from Dominic.
Thank you, Krista. Appreciate those comments. Bianca.
Yeah, sorry that it's been a little tough for me today to join the conversation. And I appreciate, Krista, that you're providing some thoughts from your team that are aiming to be actionable. And I do think that what we're looking for are actionable suggestions. I do see that one of the challenges with cumulative is just that the way the benchmark is set up, it's really based on a year to year. So having a cumulative sense of probably how costs are changing is hard then to assess based on what is really a year-to-year benchmark that's been asked of the board to measure against. Similarly, given that the costs benchmark is really based on all costs. Again, I certainly understand that there are many facets to what contributes to costs. I think understandably, there's some parts that are going to grow faster than others. And I certainly have heard these kind of conversations, and it is hard to figure out how best to compare the one, benchmark value when we know that there's multiple things going underneath. But I think that is what the cost board is trying to understand so that we can move towards also thinking about what the solutions are, is to understand, like, if costs are growing faster, what are the contributors? So it wouldn't change maybe the approach, but maybe changes the conversations about what we would do about the data that's presented to us so that we can dig in further to understand those things, like, is it the prescription drugs that are growing faster or not? I just want to also clarify, because I may have missed something too in the conversation, that I think what I heard, maybe it was Jonathan, and I think it was a reaction to maybe one of the slides here about updating the benchmark. I just want to clarify, I don't think the cost board is looking to change the approach to calculating the benchmark, but rather we're updating the data to make sure that the numbers themselves are the right numbers, right? But I think what I was kind of hearing was maybe a question or at least a reaction to a sense that we were changing an approach to the benchmark. But just to clarify, we're not changing the approach, correct?
Correct, Bianca. Right now, we're looking at a refresh to the data that's used as the inputs for the benchmark that was established by the board.
This is John. Do you have a sense of what that data is going to be? I know like the wage data in the prior one looked at from like 2010 to 19. We're just trying to get a better sense of what's taken place, what's going into it. And so any transparency in that process is appreciated. And then the point I did make is we want to make sure that the inflation factor, I know there's been lots of talk about this over the meetings that we've had, that also takes that into consideration because that is a huge, real thing. And without that being addressed, like I mentioned before, I think you lose credibility in having robust discussion around it when you're already essentially not addressing some of the pieces of reality today. So anything that you can share about the process, the data that's being used, I think is ultimately what we're asking.
Appreciate that, Jonathan. And as this is the kind of the beginning of the conversation, as I shared, this will be a topic that will come back to the advisory committees and conversations will be had, and we'll be interested in hearing perspectives alongside the way. So we're going to go back to the questions. I appreciate everyone that has shared comments and questions so far. Again, interested if ideas related to a new approach for attribution, if there's ideas or considerations that folks would like to share, or if you have any comments on other future changes. I think we're still okay on time, so interested in any comments or feedback.
Yeah, this is Jonathan. I was just curious, has there been any discussion around creating a standard approach as far as attribution goes versus allowing the different data submitters to pick and choose how they want to go about that?
Well, we've heard that comment today, and so definitely that's going to be something that we'll take back to the group and have conversations.
And, I don't know if anyone kind of read out Leah Holmarshall's comment too, that in terms of the healthcare cost growth target, that just kind of reminding that the purpose of the benchmark is how much yearly increase in healthcare costs we want it to be, so that the healthcare costs itself don't continue to be unsustainable relative to outpacing the costs that force overall spend. So that we can make sure that resources are allocated really appropriately. And I think I hear Jonathan's concern about the inflation piece, and I think that's the concern is if we increase the benchmark that it does allow for inflation, I think there is that concern that one of the reasons why we had the benchmark pegged to wages is because we're trying to take it from the perspective of what are people's wages in the state able to afford relative to the costs. And so it is actually useful to know if healthcare costs are growing bigger, faster than our set benchmarks, and then to ask questions again, why is that happening? It could be because of inflation, and that is a concern relative to the fact that wages are probably not growing as fast. I think some of this is supposed to be also tools to help us have those kind of conversations so we can figure out what needs to be under control. And it's not so easy to move everyone's wages. But is there something on the inflation side that we can control? Is there something else around the other aspects of healthcare spending that we need to do? So I recognize that there's no one kind of right answer here. Just kind of acknowledging that it is the benchmark really, I think, was designed to think a lot about what can people spend out of pocket and how are costs growing relative to what people can afford. So I appreciate Leah's comment. I just want to make sure that was kind of put out there. Leah, I hope I'm not overinterpreting kind of what you were trying to say there.
Oh, no, that was great. I appreciate that. I'm just reflecting particularly on our little slice of it. We've had 10% average premium increases for 3 years in a row and a 25% premium increase this year. Plus, with all the federal changes you saw, it's in no one's interest in Washington State for us to have 50,000 people go without insurance because they can't afford it. And that's the reality we're in.
Yeah, this is Jonathan. I just add, I mean, there's unintended consequences of not having a growth benchmark that is established in reality. I mean, you've already seen a lot of changes in the workforce in healthcare. You see a lot of that press releases there. You're also seeing access to services. I mean, these are the things that we want to talk about because one of the charge of the group is like, what are the unintended consequences of us looking at this? And so I just wanted to put that out there as well. I mean, I think we're all wanting to say, yes, let's get at the table, let's have productive conversations about this. But there are real factors in play here when you've got access and workforce shortages and layoffs. I mean, there's real things that are taking place today, and that's why we just wanted to make sure that the benchmark is established in reality. So happy to be further part of the conversations, but at the end of the day, I think in order to have those productive conversations, you can't discount that factor.
Thanks, Jonathan. Julie?
It's Julie Sylvester. Can you hear me? Yeah, I just wanted to echo what Jonathan was saying. I'm on behalf of the University of Washington. And for example, in one of our service lines where organ acquisitions, we were told by the company that acquires the organs that they've raised the rates 25% for us to, get an organ for a transplant. That's something that's completely outside of our control. And so the benchmark has to be rooted in reality. It has to be something that the providers and the systems can control. I mean, it would be no different if we said, well, for the state of Washington, we're going to hold you to a 1% growth benchmark. And you would say, well, that's unrealistic. And so that's, I think, I just wanted to say that with Jonathan, with what is happening with drugs and supplies and staffing and taxes. And, all those things are impacting all the healthcare systems. And so we need to create a benchmark that we all agree in that is realistic. I think we're all, unfortunately, we're all kind of in this boat, right? There's just not enough money right now. Funds have been cut, but, a lot of this is outside of our control as well.
Thank you, Julie. All right, before I wrap up this section, any other comments, especially as we're starting to begin the journey or looking at our attribution approach? Any? All right, Bianca, do I hand it back over? Oh, hi, Michelle.
Yeah, hi there. I'm on the advisory committee, so I just couldn't help but say that I don't recall the medical adjusted inflation rate. I think was that 4% or something? And let's say it was 4%. Our cost increases were well above 4% last year and are projected to be, our medical cost increases are projected to be 6.7% next year. So even if we could get it to the medical inflation rate, that would be progress. That's my only thought.
Thank you for your comment. All right. I'll hand it back over. I don't know if Bianca or Eileen, if one of you are the facilitators.
I think it's Eileen next.
Okay. Eileen.
Well, actually, I think it's Ross that's going to lead the next section on the legislation and bill implementation.
Thank you, Eileen. Yes, if you would advance to the next slide, please, Audrey. We were just going to give a few updates today on some of the legislation that passed last session and some of the work that's being done to implement it. the two pieces that we'll be highlighting today, we're very excited about. I'm going to highlight the healthcare registry. This is, again, a bill that was passed during last session that requires DOH in consultation with HCA and OIC to come together to draft a report which identifies the healthcare facilities and providers that should be incorporated into this provider registry that is ultimately developed with the thinking that it will be an interactive registry that is available to the public that would be able to identify providers that are in their geographic area or have a particular specialty. On the regulatory side, the really exciting piece of this legislation is getting a better, more complete picture of kind of healthcare delivery in Washington State. There's a number of facility types, healthcare facility types that are currently not regulated or not subject to registration or reporting. And so I think just getting this information will be a really big boost to our knowledge and capacity to kind of address problems. I say all that to say this legislation didn't necessarily get us all the way to the interactive registry. It funded a report with recommendations to kind of move forward with this, and also including all of the components, including the facility types that would be included, the providers, what information they would be submitting, as well as how the registry would be funded going forward. So this is just an update to say the first meeting occurred. Agencies are working to identify data within their own agencies related to healthcare facilities so that we can begin kind of putting the dots together. And we'll continue that process and meet again and continue to refine the recommendations related to facility types and, again, the information that will be provided in this registry. So, again, not a ton, has been done so far, but the preliminary work to start getting the information for the report is happening. So with that, I do see a question. Jonathan, if you'd like to go ahead.
Yeah, this is just a quick question. You kind of hit on it. When did the work group get convened? And then ultimately, it'd be nice to kind of understand who's participating in that work group.
I would be happy to look up that information. I don't have it. I would like to say it was a month and a half ago, but I'll have to look at that to see, and we can follow up as well with the folks that are participating on that.
All right, appreciate that.
Yep. Dorothy, please go ahead.
Yeah, just a quick question. Could you explain a little bit more what you mean by the business structure and funding sources of the healthcare entities?
Sure. I think what the slide is sort of stating is the more information. I don't think that there's, to my understanding at least, and again, DOH is leading this, so I stand to be corrected by them. But I believe what's being referred to here regarding funding sources is consideration for how the registry will be funded, as it will be done by the providers and facilities that are subject to the registry. So I believe that that's more speaking to the actual funding source for the registry itself. And there is some hope as well that in better understanding the different healthcare facilities in Washington, there may be some information we can glean regarding, funding and how some money moves around in our healthcare market. But I believe that's specifically referring more so to the fee collection process and how that we would go about doing that. I know there was. I'm sorry, I'm giving you more information.
No, that makes sense. I just was because my mind was going all over in terms of funding sources and business structures, and so I understand now what the intent of that bullet is. So thank you very much.
Sure. Yes. And if there is Nothing else. We'll continue to come back and provide updates. Happy to follow up with Jonathan, and maybe we can include that information as well in the next packet for the advisory committees, just so folks are aware of the work group information and when that started. And we'll continue to bring updates and hopefully can have DOH come and speak to this as well in the future. And with that, I will hand it over to Mandy Starr with OFM, who is going to give an exciting update on the state health plan work group and state health plan work.
Hi, thank you. Go ahead and go to the next slide. So this is in relation to RCW 43.370. This is updating the 2010, well, the law was actually enacted in 2007. The previous state health plan that was released was in 2010. The purpose of the law, it mandates OFM to develop a statewide health resources strategy that informs the state health plan. We'll use the term health resources strategy and state health plan interchangeably because of the previous Senate bill in the last session kind of used the terms a little bit interchangeably as well. So we've got to focus on healthcare facilities, services, quality care, cost of care. The RCW also references certificate of need assessments, and I'll talk a little bit about how we are approaching those given some changes that may happen with the certificate of need program. Next slide. To kind of get everyone on the same page of sort of where we've come in the past 15 years, we released a state health plan back in 2010. There were some major data gaps that were actually identified in that report that prevented some of the objectives actually to be completed. So we've spent around 15 years trying to fill in some of those data gaps. We did a partial update to the state health plan a few years ago, looking at just hospital utilization. Next slide. So the four main data gaps that were identified in the previous health plan was a lack of census of active healthcare professionals, the lack of a census of healthcare facilities. At the time of writing, there was no all-payer claims database. And then there was also a lack of comprehensive population-based health database. So very similar to what California has with the California Health Interview Survey. Next slide. So on the lack of healthcare census of healthcare professionals, we've been filling in a lot of the data gaps over the years, leveraging a lot of resources that are here in the state. So we had a staff member who recently retired who did a lot of work with the UW workforce studies. We've been developing methodologies to estimate different types of healthcare professionals by geographic areas. We've got numerous years of reports on our website looking at FTE counts geographically. Well over a decade ago, there was a survey of healthcare professionals that actually asked questions about hours and days of practice, different types of patient services. And we've also done just different types of ad hoc research on workforce. Next. So on the healthcare facility side, for a while, AHRQ was supporting local or regional monarch websites that had information regarding healthcare facilities. The federal agency stopped funding that a couple of years ago, and so we've had to take some of those pages down. So we've done some additional information regarding not just healthcare facilities, but infrastructure around those facilities. So distance traveled for primary care, different geographic variations in hospitals. We've also looked at hospital mergers and acquisitions, and then hospital bed capacity as well. Some of the information we can also glean from the current APCD. Next slide. The one data gap that has been filled is the launching of the all-payer healthcare claims database. OFM worked for several years through grants from CMS to launch that database and also launch the accompanying website, the WashingtonHealthcareCompare.com. So administratively, this has all moved over to HCA now. There are some gaps still within the APCD, so it does lack self-insured claims. Also, anyone who has federal insurance here in Washington State, if that's not included within the database. We are a pretty heavy user of the data, so a lot of our analysis and cost analysis especially comes from the APCD. Next slide. And then a comprehensive population health database. Again, over a decade ago, there was a Washington Healthcare Consumer Survey that actually looked at access and utilization of healthcare. We have also tried to add questions to BRFIS to try to help get at barriers to accessing care. Currently in 2025, there were 3 questions on there around medical debt. So we're really excited to see what those results are going to be like in next year or so when the data is available. But we don't have a database that really tells us what's preventing people from being able to access healthcare. What are the issues? Is it a barrier issue, like a physical barrier issue? Is it transportation? Or is it just not being able to find a provider who takes your insurance? So that information, we still lack a systematic way of collecting that across the state. Next slide. So this past session, we had Senate Bill 5568, which updated the RCW to update some of the definitions around facilities, ensured data access to OFM. We have included now the principles around health equity in the new state health plan. And I'll talk a little bit more about that in the next slide. We're also required to hold 2 hearings, 2 public hearings during this whole process. So we'll hold 1 public hearing that describes the approach that we're going to be using, and then the second public hearing will be before the final report is actually written. We have 2 deadlines. One is June 30th of 2026 that we have our approach or the outline of how we'll actually go about doing the state health plan, and then the final deadline for the first report is December 31st of 2027. We have a cadence of updating that every 4 years. In the interim of those 4 years, we're also going to be working on certain topic areas that need a little bit more focus that we won't be able to include in this first report. The example I'm sharing with everyone is oral health. We're not going to have the time or the scope or the resources to be able to cover it in this first report, but we feel that it's an important topic that should at least have some work done around it, very similar to the way we do the big state health plan. Next slide. So the principles that we are using to guide our work, transparency, will be transparent in our methods and how we go about collecting this information. We want people to be able to reproduce our results. It's not going to do anybody any good if we come up with results and numbers that nobody can actually replicate. We'll be working on protecting sensitive data. So we do need to provide information on the geographically, but we understand with small numbers that we do still need to protect sensitivity of that data. We want to avoid duplication. We don't want to do the same thing everybody else is doing. So we have a lot of one-on-ones coming up in the next couple of months where we find out what other people are doing and leverage what everyone is doing instead of duplicating those same efforts. And then we want to involve partners on varying levels of government, industry, advocates, researchers. We definitely are going to be reaching out to many people who touch the healthcare system in different ways. Next slide. So these are the key objectives. These are actually included in the RCW, so I don't have to go into too much details because they're actually included in there. The one note I do want to say is that a lot of these objectives also mention certificate of need. So it'll say, we need a health system assessment, including facilities that are part of certificate of need process. A lot of the certificate of need references, those are going to be dependent upon any decisions that DOH makes regarding the scope or function or any changes that happen to certificate of need program. So we'll stay in contact with DOH over the next year or two to see if there's any changes that we'll also need to adapt in the state health plan. Next slide. So we put together a technical advisory committee. We had our first meeting this past week. So I'm currently putting those notes together and following up with everyone. We'll be doing one-on-ones with quite a few of the people who are part of the technical advisory committee, again, to find out what type of data they have access to and also barriers to accessing healthcare data. We're working on putting together a data inventory tool that'll cover what the state currently collects around facilities, providers, utilization, access, cost, understanding where the gaps are within the state data inventories at the moment, conducting what we call a gray literature scan. So we have the peer-reviewed literature, but we want to know where the Washington specific data is. So talking to different state agencies and also different groups out there of what type of reports that they've done that are either available on their website or maybe were internal and didn't see the light of day. So we call this the gray literature search. And so it's figuring out what have people done and being able to take some of that information to include in the state health plan. We're setting up partnerships around very specific topics. Rural health is one of the biggest ones. And then we're also putting forth an IRB application. So some of the data, a lot of these data, we already have data sharing agreements set up with, but we also are going to submit an IRB application for other data sets that we may not already have. And then we've got, we have to look at health equity frameworks. The line in the RCW is just to include health equity, but there's no other guidance or requirements around it. So we're looking at health equity frameworks and also how other state agencies and also some of these other groups around that focus on health equity, what type of frameworks and guides that they're using to help guide their work. Last slide. Yep, and then you can email me if you have any questions. I'm here to take questions as well. So we're still in the beginning, but it's a pretty heavy lift. So some of you here may also be contacted by us if we feel that we'd like to meet with you, or if anybody here feels like they need to be part of this and they haven't been contacted yet, please let me know. We're open to speaking to anyone who has interest in the state health plan. Yes, Ross?
Yeah, thank you, Mandy. This question may be a little bit too prospective, so apologies. But just considering the close, obviously, nexus between the state health plan certificate of need, once this state health plan is updated, is there a runway or lag time before the certificate of need program before their decisions have to be consistent with the updated state health plan, or has there been any kind of consideration for that transition from kind of the update of the state health plan to kind of the regulatory enforcement side, or is that's a farther down the road type issue?
Yeah, that's out of scope because for us, our orders are to provide the information to certificate of need around any topics, but I know they've got rulemaking and that they would have to update as well, and so I don't have the answer for that. I think we need to talk with Ian and the state and certificate of need group to understand what they're thinking of, moving into the future as well.
Excellent. Thank you so much, Mandy, and thank you for that presentation today. That was great.
You're welcome.
Well, it looks like we're finishing up early. Ross, do you have anything more that we need to discuss?
No, we had a little bit of a lighter meeting agenda. Just a couple other quick housekeeping notes that I can mention because we have a moment. We're currently working and putting together some of the calendars, both for the cost board and for advisory committees next year. So we may be seeking some feedback on that in the coming weeks. In a discussion that we had several months ago with the advisory committees, kind of accepting feedback, there was a fair bit of one of our questions we asked was whether it was better holding these as joint meetings or whether separating them was more effective. So we're kind of looking through that process now and hoping to find some opportunities for having solo stakeholder meetings and solo data issues meetings and opportunities when they can be combined. So again, hopefully seeking some feedback here soon on those calendars, as well as the cost board calendar coming out soon. So just reiterating that we heard kind of some of those comments and are trying to incorporate that into next year's calendar. And then lastly, just wanting to put a plug in for the next two cost board meetings. We'll be having a cost board meeting on October 20th. I hope I got the right date there. I believe it's the 20th. Where October 23rd, my apologies, where we will be reviewing the preliminary legislative report for the cost board. Unfortunately, that will not include the benchmark report as that data is not ready. But if you'd be interested in reviewing the preliminary report and providing any feedback, that'll be included in the October 23rd cost board packet. And then the following month, November 20th, is when we have our public hearing. Prior to the public hearing, we will be presenting the benchmark data as well as taking any other feedback on the legislative report before turning to the public hearing. And we plan to circulate that meeting packet that includes both the legislative report and the benchmark report 2 weeks in advance of that November 20th meeting. So just letting you know, and just keep your eye out for that, and look forward to getting any feedback that folks have. And with that, I think that's all my updates. Thank you, Eileen. I appreciate that.
Okay, well, then I get, and if I'm correct, this group will not meet again until after the first of the year. And so I guess I'm going to be the first one to say Merry Christmas and Happy New Year to everybody. And we'll see you next year. So with that, meeting adjourned.
Thanks all.
Thank you, everybody.
Yeah.